In this lecture, we're going to cover your respiratory system. Let's start by looking at the functions of the respiratory system. Well, obviously, your respiratory system plays a role in gas exchange, and you're exchanging gases, carbon dioxide and oxygen, between your external environment and your blood. The respiratory system also plays a role in filtering, humidifying, and warming air that you inspire. Air is coming from your external environment, therefore it may be filled with pathogens and allergens. So remember, your respiratory system is lined by pseudostratified ciliated columnar cells with goblet cells. So remember, the cilia helps filter, and the mucus produced by the goblet cells will help humidify, add water to the air as you inspire, because your body's humidity is about 95%. And then that membrane also has very superficial blood vessels underneath it, and those superficial blood vessels play a role in warming the air. That's why your nose bleeds so easily, is because of those superficial blood vessels. Now, your nose is lined by respiratory mucosa, however your mouth is not. So your nose is better at filtering, humidifying, and warming the air. Also, remember, your nasal cavity has the nasal conchas that help the air swirl around. So if you breathe through your mouth, you might have noticed if you breathe through your mouth while you sleep, you wake up with a sore throat, and that could be because your mouth isn't as good at filtering and humidifying the air, so it dries your throat out. Also, if you go outside and it's cold and you take a deep breath through your mouth, it doesn't warm the air as well, and it can hurt your airways. The other function of your respiratory system is the production of sound, because your larynx has your vocal cords, and as air rushes out of the lungs, it vibrates those vocal cords, producing sound. Obviously, your nasal cavity plays a role in your sense of smell. As air comes in, your olfactory receptors detect chemicals in the air and gives you your sense of smell. And then one that you might not be as aware of that your respiratory system does is it plays a role in pH homeostasis, and that has to do with carbon dioxide levels. Remember, as carbon dioxide builds in your blood, it causes the acidity to increase. Okay, so your blood becomes more acidic, or a lack of carbon dioxide would cause your blood to become more basic. So by adjusting your ventilation, the amount of carbon dioxide you're moving in and out of the blood, that will play a role with pH homeostasis. So we're going to mostly talk about gas exchange today, and we'll talk a little bit about pH homeostasis. The other three we're not going to focus on too much. So let's review the anatomy of your respiratory system really quickly so you're familiar with the different areas. Obviously, air enters in through your external nares, which is your nostrils, into your nasal cavity or your nose. And then from there it moves through your pharynx, which is your throat. You have your nasopharynx, which is behind the nasal cavity, the oropharynx, which is behind the oral cavity, and then remember you have your laryngopharynx, which is the portion where it branches into either anteriorly, your larynx, where air is going to go, or posteriorly into your esophagus, where your food is going to go. So your larynx is this portion here where you have your epiglottis and your vocal cords, which then leads into the trachea, which is your windpipe, which travels through the thoracic cavity and will branch into your primary bronchi. You have your right and left primary bronchi, which are the first branches of the trachea. And then from there, these airways will continue to branch, and what we call your respiratory tree. It branches into smaller and smaller branches. And so remember, the primary bronchi will branch into secondary, then into tertiary, and finally into really small airways that do not have any cartilage on them. They're just smooth muscle, and those are the bronchioles. So your bronchioles, because they're just smooth muscle and do not have any cartilage, these are the airways that can, when you have an allergic reaction or asthma, can constrict and affect your airflow. And then bronchioles lead into eventually your alveolar ducts, which lead into the alveoli, which are the air sacs where gas exchange is going to occur. So the alveoli, along with blood vessels, make up what we call your respiratory membrane. Okay, this is important. You can't get confused the respiratory mucosa which is the epithelial lining of the respiratory system, which is pseudostratified, and then the respiratory membrane, which is the actual site of gas exchange. So your respiratory membrane is composed of the alveoli, and you can see here's your alveoli sacs, and you can see that there's a lot of capillary beds surrounding the alveoli because we want to increase the surface area for gas exchange. So you have your alveolus where air is, and then you have blood vessels. So if you were to look at a cross-section of the respiratory membrane right here, if we took a bigger picture here, you'll see that the alveolar wall is simple squamous. So this little purple part here is showing the alveolar wall. So you have air here in the alveolar space, and it's backed up to another simple squamous cell that makes up the endothelium of a capillary. So the respiratory membrane is basically a simple squamous cell that makes up the alveolar epithelium sandwiched to a simple squamous cell that makes up the endothelium of a blood vessel. So it's two simple squamous cells thick. That's as thin as we can get it right there at the membrane. And you want it thin because that's going to increase your diffusion of gases. The other thing you need to remember from anatomy has to do with the pleural sac. Now remember, all cavities that are closed to the exterior, such as your thoracic cavity, are lined by serous membranes. And the serous membrane lining the lungs is called the pleural membrane. And it's a double membrane, and the area that's lining, actually adhering to the outside of the lungs, is called the visceral pleura, and that's continuous with the pleura that then lines the cavity wall. And the part that lines the diaphragm and the cavity wall here is called the parietal pleura. Now your serous membrane is also simple squamous, okay, so it's thin, and between the two layers, the serous membranes will produce what we call serous fluid, and the serous fluid that's between the parietal membranes is specifically called pleural fluid. So this fluid, what it allows is, while the lungs expand and recoil, it allows the membranes to glide along each other, so it reduces friction in the cavity. And the other thing it does is it helps resist separation of the two membranes. So this is how I think of it. If your two membranes are two glass slides, now if you put those two glass slides together, they'll slide on each other, but they easily separate. Now if you add a little fluid between the two, they'll still glide nice and easy, but what happens when you try to separate the two? Well, now that fluid kind of suctions them together, it creates like a vacuum, and it's harder to separate them. And that's what happens with your visceral and parietal membrane. Why is that important in the respiratory system, that they don't separate very easily? Well, what happens is your lungs are actually naturally elastic, and they want to recoil, they want to move in, but you want to keep them expanded. So it pulls them open and keeps them open, and we'll talk about that in a little bit. Well, one other thing I should mention is two problems you can have if you produce too much pleural fluid or not enough. If you don't produce enough pleural fluid, the two membranes can kind of stick together too much and create too much friction, and it's painful when you try to breathe. That's one type of pleurisy, which is inflammation of the membrane where you don't produce enough of the fluid. But then there's another type of pleurisy where the inflammation causes you to produce too much of the fluid. And if you produce too much of the fluid starts to build up in this cavity, and pressure can become higher in the cavity than it is in your lungs, and it can cause the lungs to collapse. Or the other thing that can happen, I should mention, is if you have too much fluid or edema here in this cavity, it's hard for you to breathe, right? Because it's hard to expand your lungs because you're fighting against a heavier pressure. So those are kind of a few things you should be aware of if pressure changes occur based on fluid building up in this pleural cavity. So you already heard me mention the pressure, and pressure plays a role in the mechanics of your respiratory system. So we're going to look at different areas of the respiratory system and what the pressures are in those areas. So you need to be a little aware of how we figure out these numbers. When we talk about respiratory pressures, you can refer to them in two ways. You can refer to them as what the actual pressure is, and you can refer to them relative to atmospheric pressure. So what I mean by that is atmospheric pressure, let's just make it easy because this can change if you move in different altitudes, but let's just say for everything we're going to talk about today, we're at sea level, okay? So at sea level, the atmospheric pressure, the pressure outside that's being exposed onto your body, is about 760 millimeters of mercury. Okay, so that's atmospheric pressure. We abbreviate that PATM. Okay. So we can say that the pressure is 760, or we can say that it is 0 millimeters of mercury, because that would be your respiratory pressure as described relative to atmospheric pressure. So if your respiratory pressure is 760 equal to atmospheric pressure, we'd say your respiratory pressure is 0. Okay. Now if we say you have a negative respiratory pressure, that means it's less than atmospheric pressure. So let's say the pressure in the lungs was actually 759, that would be -1. Okay, so if we say the pressure is -1, you know that it's 1 less than atmospheric pressure. If we say you have a positive pressure, then that means it's greater than atmospheric pressure at sea level. So if you're at 764 or 761, then you have a +1 respiratory pressure. Okay. So let's think about that. Let's see if you understand what we're saying here. What if the pressure in your lungs was 764? What would your respiratory pressure be? You'd compare it to atmospheric pressure, and it's 4 greater. So you would have a +4 or a positive pressure. Does that make sense? So you might see in textbooks where they write it as what the actual pressure is, like 759, 761, or you might see in textbooks where they'll write it as -1, +1, +4. So just be aware of that they can be written either way. So let's look at how the pressure varies in different areas of your respiratory system. Now you have 2 types of pressures you should be familiar with. There's intrapulmonary pressure, and there's another name for it, which is alveolar. Either way you refer to it, but you should be familiar with both. So it's either called intrapulmonary because it's within the respiratory system, or it can be called alveolar pressure. And that's basically the pressure within the alveolus. Your alveoli, the air sacs, are technically open to the exterior, right? Through the respiratory branches, eventually through the trachea and through your mouth and nose. So if you open your nose and mouth and sit there, the alveoli pressure will equate with the exterior pressure. So we can usually say that your alveolar pressure is equal to atmospheric pressure, 760. If you're not breathing or anything, you're just standing there with your mouth open. Now, intrapleural, intra means within the pleural cavity. Okay. So this is the pressure in the pleural cavity outside your lungs, the area between your lungs and your thoracic cavity wall. Now this area is close to the exterior. Okay, it doesn't open to the exterior. And so that's the pressure within the pleural cavity. Now it's important, in order to keep your lungs open and keep them from collapsing, that this intrapleural pressure is always less than the alveolar pressure. If this intrapleural pressure becomes greater, it can cause your lungs to collapse. So that leads us to what we call your transpulmonary pressure. It's the difference between the intrapulmonary and the intrapleural pressure. And like I said, you want it to always be, the intrapleural pressure in the cavity always needs to be less than the intrapulmonary pressure. Now it changes as you breathe, but in general it averages to about -4 millimeters of mercury. So that means that the intrapleural pressure is usually about 4 less than the intrapulmonary pressure. So let's look at this again. So it's about 760 in the alveolus. It's less. It's a negative pressure in the pleural cavity, and then this is showing you the pressure that would be on your thoracic wall from the outside. So on your skin outside, Obviously the air would be at atmospheric pressure about 760. Now, as I said, it's very important that this intrapleural pressure stays less than the alveolar pressure or intrapulmonary pressure, or your lungs will collapse. So when your lungs collapse because there is a puncture that occurs and allows that pressure in the cavity to equate, then that's called a pneumothorax. And there's two types of pneumothoraxes. One is it could be what we call a traumatic pneumothorax, where you actually puncture the thoracic cavity wall. So this would be something like a chest wound, okay, if you're stabbed in the chest. So now when I open up that cavity, the pleural cavity, to the exterior, what's going to happen is air likes to move from a higher pressure to a lower pressure. So pressure outside would be at atmospheric pressure, 760, but remember in the cavity it was less than that. It was 756 or -4. So air is going to move into the cavity, and when air moves into the cavity until it's equal, it can cause the lungs to collapse. Now another type of pneumothorax you can have is what we call a spontaneous pneumothorax, and that's when you actually have a hole that happens in the lungs. They're not sure what causes this, it's just spontaneous, bad luck. They have seen that it tends to happen in a certain population, tall, white men in their late 20s or early 30s. Why it happens, not sure. But what happens is if you have a hole that happens in this direction in the wall of the lungs, the same thing can happen where air is going to move from the alveolus into the pleural cavity, because it's going to equate with the exterior because your respiratory system's open to the exterior, and you'll get the same problem. Okay. Now, as I said before, you can, without having any holes happen, let's say we close up these holes, you can have where pressure becomes greater in the pleural cavity, and that could happen because of edema, swelling, okay, or sometimes it happens in what we call congestive heart failure, because blood tends to back up in the pulmonary circulation and fluid moves out into the tissues, and that can cause a collapsed lung. Or any type of bleeding in the thoracic cavity may increase the pressure too. Alright, so that's your anatomy review and kind of a general review of pressures. Now we're going to talk about the different events of respiration. So there's different things that have to happen to get blood or to get gases from the exterior to your cells, and then from your cells back to the exterior. Because first thing we need to do is what we call pulmonary ventilation. We need to get air in and out of the respiratory system. So pulmonary ventilation is basically breathing, okay, getting air to the alveolus or from the alveolus to the exterior. Then you have what is called external respiration, which is the gas exchange between the alveolus and the blood across that respiratory membrane. So this would be where you have external respiration. Obviously here oxygen is going to move into the blood, carbon dioxide is going to move from the blood into the alveolus. Then you need to transport gases in the blood to and from the tissues. So we'll talk about gas transport, how you transport oxygen, how you transport carbon dioxide. And then we'll talk about internal respiration, which is the second side of gas exchange. So you're going to have a second gas exchange between the blood and the tissues. So oxygen is going to move into the tissues so the cells can use it for cellular respiration. And the cells make carbon dioxide that needs to move from the tissues into the blood so it can get to the lungs for you to exhale it, because it's a waste product. Internal respiration is happening between the tissues and the blood. External respiration is happening between the alveoli and the blood. In our lecture, we're going to go through these. We're going to first talk about pulmonary ventilation. We'll talk about how you get gases across that respiratory membrane. We'll talk about how we transport it, how gases are exchanged at the tissues. So let's start with ventilation. The definition of ventilation is moving the air in and out of the lungs, so just getting it to and from the alveoli and the exterior. Now this is a mechanical process, which means you're going to have changes in volume within the thoracic cavity that will move the air. Okay. How do you change the volume of your thoracic cavity? Well, you're going to use muscles. to expand the rib cage and also move the diaphragm. So contraction and relaxation of your intercostal muscles and your diaphragm will change the respiratory volume. Now, if you change volume, that changes pressure. And if you have a change in pressure, you have flow of gases. Because you need to remember, and you should have learned this in chemistry, gases will move from a higher pressure to a lower pressure. So if I change pressure by changing volume, I'm going to be moving gases in and out of my lungs. So this idea has to do with Boyle's law. Boyle's law was the relationship between pressure and volume. And the idea is, if you have a larger volume and the same amount of gas molecules, you have a certain pressure. If you reduce that volume in half, but you have the same amount of gas, pressure is going to double. If you have a smaller area with the same amount of air in it, your pressure is going to be higher than if you expand that volume, your pressure is going to drop. So how do we get air moving? Well, we're going to change the pressures by changing the volume. Okay. So as you breathe, intrapulmonary and intrapleural pressures will fluctuate. You have kind of two phases of ventilation. You have inspiration, where you breathe in and air flows into the lungs, and you have expiration, where you exhale and air will leave the lungs. Okay. So what's happening in these two phases? So if you look at these two charts here, this is volume of your thoracic cavity. And as you inhale or inspire, the volume of your cavity will increase. And as the volume of your cavity increases, air is going to move in. Now, why does that happen? If I increase volume, and the way you increase volume is you guys know that when you inhale, your thoracic cavity gets bigger. You can feel it. So if volume increases, what's going to happen to pressure? Well, the pressure in my intrapulmonary space, or in the alveoli, will drop. As volume increases, pressure drops, and it becomes negative compared to the outside. And as it becomes negative, obviously that's going to drive air in, because air is going to want to move from a positive pressure in towards the negative pressure, to where there's less pressure. Now, as you exhale, your lungs recoil. Okay, you relax your respiratory muscles and the lungs recoil. So now you have all this air in your lungs, but your volume is starting to decrease. And as the volume starts to decrease and the air is still in there, pressure starts to get higher. And once pressure gets greater than it is outside, okay, once it becomes positive, that's going to force air out, because air is going to want to move from its higher pressure to its lower pressure. So let's go over these events one more time. So as you inhale, okay, your medulla triggers the diaphragm and the intercostal muscles to contract, and your rib cage rises, it swings out, and the diaphragm actually, when it contracts, your diaphragm's dome shaped, right? When the diaphragm contracts, it flattens out, it moves down. So if it flattens out, it's increasing the volume of the thoracic cavity, which causes the pressure to drop, becomes negative, and that will cause air to move from the outside into the inside of the alveoli at least until the pressures equate. So until the pressure is back to zero. Then what happens is you inhibit the contraction of those intercostal muscles, and basically when you stop them from contracting, they will relax. And when they relax, your rib cage descends back to its original position, and your diaphragm relaxes and it domes back up and moves up. So that's going to decrease your thoracic cavity volume. So what that means is the pressure will go up. And once the pressure becomes greater than it is outside, air will move out. So let's look at some factors that affect ventilation. One thing that affects how well you can move air in and out is what we call lung compliance. And lung compliance is the ease at which the lungs can be expanded. Okay. Now I want to bring this up right now. There's another factor which is called elasticity. Now, elasticity is different than compliance. Compliance is the ease in which you can expand the lungs. Elasticity is how readily the lungs recoil after you expand them. So we tend to think of as elasticity as stretchy, and it does go both ways. You can stretch something, but elasticity is how well it recoils. Compliance is how well it stretches to expand it. So if you have a balloon, it's both compliant and elastic. You can easily add air to it, and it expands easily. And then when you let the air out, it easily recoils. So it has both compliance and elasticity. Now if you compare that to a plastic bag, it has compliance, but it does not have elasticity. So if you blow air into a plastic bag, yes, it will expand easily. But is it going to recoil after you expand it? Not necessarily. Okay, so it would have compliance, but not elasticity. So I think that's a good analogy to kind of show you the difference between the two. Things that will affect your lung compliance. If something reduces compliance, it's going to reduce ventilation. You're not going to be able to get air in as easily. So anything that provides resistance to the distension of the lung tissue. So things that can affect the extension of the lung tissue. One we already kind of talked about, pulmonary edema. If you have fluid building up around the lungs, it's going to be you're going to have to work harder to inflate them. The other thing is fibrosis. Fibrosis is scarring of the tissue. Now, scar tissue is mostly collagen, and you should have learned in anatomy that collagen is designed to resist pull or multidirectional force. So if you have a lot of collagen fiber, it doesn't like to stretch. And the other thing that's reduced by is what we call surface tension of the alveoli. And we'll talk about this in a bit, but you have your alveoli here. The inside of your alveoli has a lot of water molecules in it. And water molecules, remember cohesion, they're attracted to each other. They want to naturally pull the alveoli closed. So if you increase surface tension, it's pulling this way. Whereas compliance is you want to expand and pull that way. So if you increase the surface tension, you're going to hinder compliance. And we'll talk a little bit more about that on our next slide. Now, elasticity is how readily the lungs recoil after stretching. Now, a healthy lung is very, very elastic. Your lungs, naturally, as soon as you stop breathing or inspiring and you relax those respiratory muscles, the lungs naturally want to recoil. So the reason is you have a lot of elastic connective tissue in the lungs. The other thing is that surface tension of the alveoli. It's tending to pull the lungs in. Now, what can happen is as you get older or in certain disease states such as emphysema, all that elastic connective tissue starts to break down. And if you start to break down that elastic tissue, you lose the elasticity of the lungs. And we'll talk about this when we talk about the difference between obstructive and restrictive respiratory disorders. But you can have disorders that affect just the elasticity. So people are able to get air in, but they have a harder time getting the air out because they've lost that natural recoil. Or you can have diseases that affect the compliance, but not the elasticity. So in that case, people have trouble getting the air in and expanding the lungs. So here's just a little closer look at the surface tension that I was talking about. In your alveoli, okay, it's a moist membrane, so there's water in there. You know, your alveolus is a round structure for the most part, and you have all these water molecules. Well, they're attracted to each other. So they're going to be pulling towards each other and pulling towards the center of the alveolus, somewhat making your lungs or your alveoli want to collapse. Okay. Now, we don't want our alveoli to collapse every time we exhale. Like I said before, if you have two wet membranes stuck together, it would take a lot of effort to reinflate them. Okay, like if you added water to your balloon, it would be harder for you to reinflate the balloon. We have in our body, we produce a chemical called surfactant, which is basically what we call a detergent-like complex. It's basically a lipid proteins compound that helps reduce the surface tension to help keep the alveoli from collapsing every time we exhale. So surfactant starts to get produced, I think they say about 28 weeks, I believe it is. And so if they're born before that, their lungs might not be able to stay inflated, so they either have to be on a ventilator, or now they can actually squirt a medication that acts like surfactant into the lungs until they start producing their own surfactant to keep their lungs from collapsing. Another factor that's going to affect ventilation is airway resistance. So friction is a major source of resistance to airflow. If you increase the friction in the airways, airflow isn't going to occur as easily. And you've learned this equation already when we talked about blood pressure. So now we're just talking about airflow is equal to the pressure gradient and the resistance. So if we increase resistance, we're going to decrease flow. Another way you can look at this, because this is going to come into play later, if I increase the pressure gradient, if I make it a greater difference between the exterior and the interior, that will increase flow. So the main thing that's going to affect resistance in your airways is your autonomic nervous system that controls the diameter of the bronchioles. You can bronchodilate, dilate the bronchioles, open up the airways, and if you open up the airways, you have less resistance, so airflow will be better. Or you can bronchoconstrict, which will constrict the airways, and you'll have more resistance to airflow. So this is mainly controlled by the autonomic nervous system. The sympathetic nervous system will cause bronchodilation. Remember, because if you're in sympathetic, you want to increase your respiration. Parasympathetic will cause bronchoconstriction, or it mainly makes it go back to its normal diameter. Okay, and that would increase resistance compared to sympathetic. Now there's also some diseases that will affect airway resistance, and these are called chronic obstructive pulmonary disorders, or we call those COPDs. You've probably heard of that. And it's a group of diseases that increase resistance. So asthma, bronchitis, or emphysema can be categorized as chronic obstructive pulmonary diseases. And in that case, in bronchitis and asthma, it's pretty much an inflammation of the airways. And when you have inflammation, you're releasing chemicals that can cause bronchial constriction. Also, you tend to have mucus production. And if you increase mucus production, you could be obstructing airflow. And then emphysema also can lead to inflammation and can be a chronic obstructive pulmonary disorder. Let's go back to our equation really quick, because I just want to go back to how you can counteract an increase in resistance. So in these disorders, I have an increase in resistance, right? So if I increase resistance, but I want to keep my flow the same, because it's important to get air into your airways. So even though if my resistance is going up, but I want to maintain flow, how can I counteract that resistance? Well, the way you can counteract it is to increase the pressure gradient. So I can increase the pressure gradient to counteract that resistance. So how are you going to increase the pressure gradient to get air in and out? Well, you're going to have to change the pressure in your lungs, intrapulmonary pressure. And the way you're going to do that is by working harder to change the volume. Because remember, change in volume changes pressure, causes flow of gases. So let's look at this. In a healthy lung, all I need to do to exhale, to get air out, I just need to increase my alveolar pressure a little bit. I just need to be a little higher than it is outside, and that will cause the gases to move out. Now, in someone that has a chronic obstructive pulmonary disorder, that's not necessarily the case, because they have constriction in their airways, or resistance. They have more resistance. So what that means is I have to create a higher pressure to force air out through that system. So what that means is I'm going to need to get my pressure a lot higher in the alveoli than it is outside, because I got to force that air through an area where you have more resistance to flow. Does that make sense? So a lot of times what they have to do is to exhale even harder and create a higher pressure. Now, people that have COPDs, they have trouble getting air both in and out, but they can counteract getting air in. And the way they can counteract that is they can just expand their rib cage more. So they labor more to breathe, but they really take in a deep breath, really deep. And so what happens is they can suck air in. They do have to work harder to overcome that resistance, but they can suck in air. Where they have a real problem is getting the air out. And the reason they have a real problem getting air out is they have to create such a high pressure in their thoracic cavity to get the air out, is air gets trapped in the airways. You can't really get it out. Because when you create such a high pressure and as air is moving out, eventually what will happen is the pressure gets higher in the pleural cavity than it is in the small airways as air starts to move out. And as it starts to equate, you can see this here, as it starts to equate to the intrapleural pressure, it will collapse your airways. And so you're trying to forcefully get the air out, but you're having to create such a high pressure that eventually it closes your airways and the air gets trapped in the alveoli. So people with emphysema, they can get air in by laboring to really increase that thoracic volume and create a greater pressure gradient to get air in to overcome the resistance. But when they try to force the air out, you have to really create a high pressure in the pleural cavity, and it could cause the airways to collapse and the air gets trapped. So this leads to one of your symptoms of COPDs. They retain air, therefore what they're doing is they're retaining carbon dioxide in the lungs. Okay, they're having trouble getting carbon dioxide out. We'll talk about this a little later about how that retaining of the carbon dioxide causes them problems. Alright, so here's a review of factors that will affect airway resistance. The main one we just talked about was just the diameter of the airways. Obviously, if you have a physical obstruction, such as mucus or something else in there, you have buildup when you're sick or when you have asthma or bronchitis, that's going to increase resistance and therefore affect ventilation. Then you have the diameters of your bronchioles. So bronchial constriction, which can be caused by parasympathetic nervous system. Or we also talked about if you have an immune response or if you have an allergic reaction, chemicals that are released in inflammation such as histamine or leukotrienes can cause bronchial constriction. So that's why in allergic reactions, people's airways close up. And then bronchodilation will increase ventilation by decreasing resistance. And things that can cause that is, we'll talk about carbon dioxide, and then we talked about sympathetic nervous system, which is epinephrine. So, we just talked about a few things that affect ventilation. Let's go back and recap them. Lung compliance, how easily you can expand the lungs, get air in. Elasticity, how well the lungs recoil to get air out. And then resistance to airflow. So those are the main things affecting ventilation. So you can test how well ventilation is occurring. And the way you measure the gas exchange is we look at what we call respiratory capacities. And that's measured with a tool called a spirometer, or this is called spirometry. And a spirometer is an instrument that measures respiratory volumes and capacities. Now there's what is called wet spirometry, which is you basically have this bell that's inverted over water, and you breathe in and out of a tube and it moves the bell up and down. That's called wet spirometry. There's also what is called dry spirometry, which is what you guys will use in lab to measure respiratory functions. And the reason we can use spirometry is it allows us to distinguish between two types of respiratory disorders. Obstructive pulmonary disorders, which is an increased airway resistance, and then there's what is called restrictive disorders, which is caused by a reduction in lung compliance. So they have trouble getting air in, okay, and this could be caused from a structural or functional change in the lungs. Okay, so we'll talk about how obstructive pulmonary disorders, what happens to their respiratory volumes, but they tend to have trouble, like I talked about, getting air out. And restrictive disorders tend to have trouble getting air in. And that's a real generalization, but that's how you can start to think about it. So first, you have to learn some terminology. All the different respiratory volumes have different names, and you're going to learn these in lab as well and test these volumes. This is where lecture and lab will overlap, which is nice. Now, your tidal volume is when you're just normally breathing. Okay, you're not forcefully inhaling or forcefully exhaling, you're just passively breathing. Okay, and you're moving air in and out of the lungs. When you're passively breathing, you're moving about 500 milliliters of air in and out. Now if you look at a spirogram, that would be a recording of these respiratory volume changes over time. So you can see this like on a physiograph, which you'll do in lab. So now your vertical here is volume, change in volume, and your horizontal is still time. An increase in volume, and then when you breathe out you see a decrease in volume. You see that on the graph? So that little change there would be a normal breath, a tidal volume. And if you measure the difference between these two, it would be about 500 milliliters. Then you have what is called the inspiratory reserve volume. That's the amount of air you can take in above and beyond your tidal volume. So this isn't passive anymore. This is where you forcefully do it. So you can take in a normal breath. You can't see me do this online, but imagine you taking a normal breath. And then you use your respiratory muscles to take in more air. Okay, you inhale as much as you can. That's your inspiratory reserve volume. So you can actually measure your inspiratory reserve volume on this graph. So you take in a normal breath, and then everything above and beyond that normal breath, you can see here, this is the max you can take in. Okay, up to, let's say, about 5,700 milliliters or 5.7 liters. The difference between your tidal volume and the max you took in is what we call your IRV, or your inspiratory reserve volume. That's about 21 to 3,200 milliliters. You don't need to memorize this number here. You do need to know, I will quiz you on your tidal volume. So you should know that your tidal volume is about 500 milliliters. I'm not going to make you memorize these numbers here for your other volumes, but you should obviously know that your inspiratory reserve volume is bigger than your tidal volume, or it should be. Now you have the same thing with your expiratory reserve volume. You can exhale 500 mils when you're normally breathing, but you also know that you can exhale forcefully air beyond that. So I exhale passively, but then I can use my intercostal muscles to force more air out. So that amount you force out after your tidal volume is your expiratory reserve volume. And you can see that on this graph here. You've forced out your tidal volume here. That's my 500 mils. And then I'm going to exhale even extra out. Okay, and that's the max you can exhale out. No matter how forcefully you exhale, you can exhale as forcefully as you can till you're red in the face. There's still air that you cannot get out of your respiratory system. And that air gets trapped in the lungs. And that's what we call your residual volume, or your RV. So you can see on this graph, it's about 1.2 liters, or 1,200 milliliters. So this is your residual volume. It's trapped in there. Why do you have residual volume? What's the importance of it? Well, there's two things. One is you always want to have some air exposed to that respiratory membrane because it keeps consistency with your gas exchange. So that gas exchange between the air and the blood is consistent. Okay, it's always happening. You don't want to completely empty the lungs and have a moment where you're not having gas exchange. The other thing is, remember I told you if you completely empty the lungs, that the alveoli will kind of stick together due to the surface tension, and then you'd have to labor more to breathe. Now if you look at your tidal volume, how much of the 500 mils is actually reaching the alveoli? Because remember, you have, maybe you remember from anatomy, you have your what we call the conducting zone of the respiratory tract. It's all the passageway from your mouth to the alveolus. So that'd be like the trachea, the bronchial tree, before you reach the alveoli, which is where you actually have gas exchange. So the conduction zone is just conducting the air. The respiratory zone is your alveoli, where you have actual gas exchange, okay, between the alveoli and the blood. So out of that 500 mils, about 150 of it stays in the conducting zone. It never actually reaches the alveoli, whereas about 350 of it actually reaches the respiratory zone where you have gas exchange. So the amount that actually reaches the area of gas exchange we call the functional volume because it's being used for gas exchange. The rest what we call the dead space volume. So technically your tidal volume can be divided into the dead space volume and the functional volume. So those are volume. Then there's also what we call capacities. And respiratory capacities are two or more volumes added together. So your inspiratory capacity is the total amount of air you can inspire. inspiratory capacity would be your tidal volume plus your IRV. On this chart, you can see where you would measure to figure out your inspiratory capacity. You'd want to include your tidal volume. So if I wanted to measure my inspiratory capacity on a spirometer, I'd first have to exhale normally. Then I'd have to inhale as much as I can. Now your expiratory capacity would be the total amount you can exhale after a tidal inspiration. So if I take in a normal tidal inspiration, which you're seeing on the spirogram, I take in my 500 mils and I'm up here, and now I forcefully exhale. That's going to include my tidal expiration here, plus the amount I can forcefully exhale beyond that. So this graph doesn't mark the EC, but technically your EC would be from here, because it would include this area here, your tidal expiration, down here to where your ERV ends. Okay, so this entire area. Then you have what's called the functional residual capacity, which is the amount of air remaining in the lungs after a tidal expiration. So this is not after a forceful expiration, it's after a tidal expiration. So you can see that here, because if it's after an ERV, or after your expiratory capacity, that's just your residual volume. If it's after a normal passive expiration, you would have your ERV plus your residual volume, which would be your functional residual capacity. So you see here, capacities are two or more volumes added together. You have your vital capacity, okay, or we abbreviated VC, which is the total amount of air you can actually exchange. So this could be forcefully exchanging. Okay, so it's the maximum you can take in, the maximum you can exhale, the amount you can exchange with the environment. Technically, your VC is your expiratory reserve volume plus your tidal volume plus your inspiratory reserve volume. So if you wanted to measure this in lab, you would take in your maximum inspiration, as much as you can take in, and then you would forcefully exhale everything you can. And that difference would be your vital capacity. You also have what's called total lung capacity, the total amount of air your lungs can hold. This is different because it's not actually requiring you to exchange the air. So your total lung capacity is your VC, the amount you can exchange, plus the amount that stays in there, which is your residual volume, right? So your total lung capacity is including your residual volume down here. So to figure out what your total lung capacity is if you just inhale the maximum amount you can, at that moment, the amount of air that's in your lungs, the total amount of air that's in your lungs, is your total lung capacity. So it includes that residual volume. The other thing you can look at for respiratory function is your total ventilation. And total ventilation is the amount of gas that flows in and out of the respiratory tract in 1 minute. I kind of think of it kind of like cardiac output. Remember, cardiac output was the amount of blood you pump per minute? Well, total ventilation is the amount of air you move per minute. So the way you can figure out the amount of air you move per minute is you first have to look at how many times you breathe per minute, which is your respiratory rate, and then you multiply it by the volume you move for each breath, which would be your tidal volume if we're talking about normal breathing. So for example, to calculate your total ventilation, the amount of air you move per minute, let's say you take 12 breaths per minute. Normal breathing, usually people take between 12 and 14 breaths. Okay, that's called eupnea. Eup means normal breathing. And each time you move 500 milliliters per breath, so you would do 500 times 12, so each minute you're moving about 6,000 milliliters per minute, or you could say you're moving 6 liters per minute. Now another test that they do is forced vital capacity. So you're going to actually test this in lab, your FVC, forced vital capacity. It's basically how much you can forcefully exhale and how quickly you can do it. And then you look at how quickly you can get that air out. And this is your forced expiratory volumes. Okay, it's the amount of gas you can expel for a specific time. So you're going to do this in lab. You're going to figure out your forced vital capacity at 1 second. You're going to figure it out at 2 seconds, how much you have out at 2 seconds. And then you're going to figure out how much you have out at 3 seconds. Now this is to test for obstructive pulmonary disorders, because remember I told you that people that have obstructive pulmonary disorders, they have trouble getting air out. So in a healthy individual, you should have like 99% of your air out by 3 seconds. A lot of people can get like 80% out in 1 second and then 100% out by 2 seconds. It's all out. Someone that has obstructive pulmonary disorder, they might only have 50% out by 3 seconds. They're still trying to get the air out. Okay, so that's why this test, forced expiratory volumes, looking at how much you can get out per second, can help you distinguish if you have an obstructive pulmonary disorder. Spirometry can somewhat also tell you the difference between restrictive or obstructive. You'll see some differences. Okay, so restrictive disorders, remember I mentioned, they have trouble getting air in. They have trouble with lung compliance. Examples of restrictive disorders: anything that reduces that compliance. So fibrosis, if you have scarring of that tissue, it's going to affect compliance. Edema will affect compliance. If you have edema, which can be caused by pleurisy. Pneumonia is a restrictive disorder because it causes fluid buildup in the pleural cavity. Okay, so those are examples of restrictive disorders versus obstructive disorders, which cause an increase in airway resistance. So we talked about those: asthma, bronchitis, emphysema. So obstructive disorders, they have trouble getting air out. So if you look at a spirogram of someone with an obstructive disorder, their capacities usually look okay, their vital capacities and the total lung capacity, because they can counteract getting air in by increasing their thoracic cavity. And sometimes that's why people with chronic obstructive pulmonary disorders, they tend to have large respiratory muscles because they're laboring. They build those muscles up to get air in, to change the pressure gradient. We say that they may look barrel-chested. They tend to have a large thoracic cavity. They can counteract getting air in, but they have trouble getting air out. So what you'll see is they'll tend to have a smaller ERV because they're having trouble getting air out, and what that leads to is they get more air trapped in their lungs, so they'll have a higher residual volume. Now someone that has a restrictive disease, they have trouble getting air in because they've lost lung compliance. So you will tend to see that their vital capacity and total lung capacities are smaller, and they have a smaller inspiratory reserve volume here. But they'll have a normal ERV and a normal residual volume because they don't have trouble getting air out. They're being restricted with their compliance and getting air in. So we just talked about ventilation, getting air in and out, and the different things that affect ventilation, and then how we can test ventilation with spirometry. Now we're going to talk about things that affect external respiration. And remember, external respiration is the gas exchange between the pulmonary blood and the alveoli across that respiratory membrane. So you have your alveoli here and you have your pulmonary circulation, and you're going to have gas exchange between the two. Oxygen is always going to move, or you're hoping it's moving, from the alveoli into the blood. Because remember, in your pulmonary circulation, blood coming from the right side of the heart is oxygen-poor blood. Okay, so oxygen is going to move from the alveoli into the blood, and it's rich in carbon dioxide, and carbon dioxide is going to move from the blood into the alveoli for you to exhale. And then the blood returns back to the left side of the heart, and it's nice and rich in oxygen, and it's being ready to be pumped to the body. So that's external respiration. Oxygen moves from the alveoli into the blood, carbon dioxide moves from the blood to the alveoli. So what causes the gases to move in this direction? Well, there's different factors that are going to influence the movement. One is partial pressure gradients. Okay. Gases always move from a higher partial pressure to a lower partial pressure. So that's driving gases in the direction that they move. The other is gas solubility. How well the gas dissolves in either air or the plasma. Plasma is mostly water. The other thing that affects external respiration, how well those gases will move, is ventilation, because obviously you do need to get the air there to the membrane for it to move across, and you also have to get the blood there. So it's important to match the ventilation with the perfusion of the blood in the pulmonary circuit. It wouldn't help if you have good ventilation but poor blood perfusion to that area. And then there's some structural characteristics of the respiratory membrane that influence external respiration that we'll talk about. So let's first look at partial pressures. Now you probably learned this in chemistry, Dalton's law. It has to do with partial pressures, and the law states that the total pressure exerted by a mixture of gases is the sum of the pressures exerted independently by each gas in the mixture. What does that mean, simplified? You guys know that air is a mixture of gases. There's nitrogen, oxygen, and carbon dioxide in air. Now, we learned that the pressure, atmospheric pressure of air, is 760 millimeters of mercury. Well, out of that, how much is nitrogen responsible for? How much is oxygen responsible for? How much is carbon dioxide responsible for? So we can figure out what their partial pressure is for each gas. The partial pressure of each gas is directly proportional to its percentage in the mixture. So what that means is if you look at air, it's mostly nitrogen. 78% of the gases found in air is nitrogen. Nitrogen accounts for 593 millimeters of mercury. These were my calculations here. They're showing a slightly different calculation here. They're rounding up 79. So they're saying that nitrogen is responsible for about 600 millimeters of mercury out of your 760. I have 593. But basically, nitrogen has the highest partial pressure. Oxygen's about 21%, so its partial pressure in air is 160. And carbon dioxide, it's only 0.9%, so its partial pressure is very low. Basically what they did here is they didn't count carbon dioxide in here because they're saying that it's so small. So they rounded up saying that 79% was nitrogen, 21% is oxygen. But there is a small partial pressure that is carbon dioxide because carbon dioxide is found in air. It's part of the mixture. So what this means, okay, so in the air that you inhale that enters into your alveoli, the partial pressure of oxygen is 160 and the partial pressure of carbon dioxide is 7. And I told you that gases move from their higher partial pressure to their lower partial pressure. Oxygen moves into the blood from the alveoli, and the reason it's moving is the alveoli have a higher partial pressure. That's what this abbreviation stands for. PO2 is partial pressure than the blood does. It's actually 100, and I'll explain that in a minute. As air moves through your respiratory tract, it gets humidified, and so it's changing the composition of the air as you add water to it, so the partial pressure kind of changes. By the time the air enters the alveoli, the partial pressure of oxygen is about 100. And that's higher than the partial pressure of oxygen in the blood. Okay, so oxygen is going to move by diffusion to the area of lower partial pressure. Now, carbon dioxide is going to move out of the blood into the alveoli because the partial pressure of carbon dioxide is really low in the air, and it's higher in the blood that's coming back from the tissues. When you inhale air, okay, we say that the partial pressure of oxygen is about 160, it's about 0.23 for carbon dioxide. By the time it reaches the alveoli, I told you because it gets humidified, partial pressure of oxygen is about 100. Well, in the venous blood, partial pressure of oxygen is 40, so it's lower. So that's what's driving oxygen across the membrane because it's going to move to its lower partial pressure basically until those partial pressures equate. It will equate to about 100 partial pressure in the blood, okay, and then oxygen will stop moving. And then carbon dioxide moves out of the blood because it's about 46 in the blood and it's about 40 in the alveoli, so it will move to its lower partial pressure. Now another factor that goes into that is what we call gas solubility, and this is Henry's law. Henry's law states that gas will dissolve in a liquid proportional to its partial pressure. What determines how soluble it is when its partial pressures equate. This is a little confusing, but let's see if we can understand this. Air is a different mixture than water. So when you're looking at concentration of oxygen, if I get to a partial pressure of 100 millimeters of mercury, in air, volume-wise or concentration-wise, that would be about 5.2 millimoles per liter of air. Okay. Now, a partial pressure of 100 in water will be different because water is a different mixture. And remember that your partial pressure is a percent of the composition. So a partial pressure of 100 millimeters of mercury in water would only be 0.15 millimoles of oxygen. So that's a lot lower concentration than what you have in air. And the idea is that oxygen is going to move from air into water, which is basically what your plasma is, until the partial pressures are equal. Now this causes you a problem. This means that oxygen isn't very soluble in water, because what it means is very little oxygen is actually going to move into the water. Only 0.15 millimoles will move into water. So we would say that oxygen has a pretty low solubility in liquid. Now if you look at carbon dioxide, on the other hand, it has a lot higher solubility in liquid than oxygen. It's about 20 times more. So if we look at the same concentration of carbon dioxide, 5.2 millimoles per liter. If my partial pressure of carbon dioxide is 100 millimeters of mercury in air, and I was to get to 100 millimeters of mercury in the water, that would actually be 3 millimoles. That's a lot higher than 0.15 millimoles. So that means that quite a bit more carbon dioxide will diffuse into the water before it equals partial pressures. Now, nitrogen is practically insoluble in plasma. So that's why even though air is 78% nitrogen, none of that's really going to get into your plasma. It's insoluble. Now that can change. If you increase the partial pressure high enough, or increase the pressure high enough, you can start to drive nitrogen into the blood. And this is what can happen with people that are scuba divers. When you're at a really high pressure, nitrogen can start to dissolve in the blood, and that causes nitrogen bubbles in the tissues, and it leads to the bends. It's a condition that can happen in people that are scuba diving due to the nitrogen becoming soluble. So why am I telling you all this? Basically, what it comes down to is oxygen is less soluble in the plasma than carbon dioxide. But what we need is we need to get all that oxygen in here. 0.15 millimoles per liter is not going to be enough oxygen for your tissues. So you have an adaptation that keeps oxygen moving into the plasma. And that adaptation is hemoglobin. Now, hemoglobin, what it does is it binds up the oxygen that's in the plasma. So it binds up the oxygen and gets it out of the plasma, basically. I know that's kind of confusing because you're thinking, well, your blood cells are floating in your plasma. But think about it, if I pull it out of the plasma and actually bind it to a cell, it doesn't count in the plasma. So what that means is it keeps your plasma partial pressures of oxygen lower than what it is in the alveoli, so it keeps driving the oxygen in. And so it leads to a larger net transfer of oxygen. We'll talk about this in a bit, but oxygen, about 98.5% of your oxygen saturation is the amount of oxygen being carried in the blood. About 98.5% of it is being carried on hemoglobin. You do have a small amount, about 1.5%, that gets dissolved in the plasma. And that 1.5% is that 0.15 millimoles. Okay, but that's not enough to sustain life. So that's why you have hemoglobin. Isn't that interesting? I think that's very interesting. That's why, because of the poor solubility of oxygen. Another factor that's going to influence external respiration is that you need to match your ventilation, the amount of air getting to the alveoli, with the perfusion, the amount of blood coming to the alveoli for gas exchange. You don't want to waste perfusion on an alveoli that's poorly ventilated. You want them to somewhat be matched, because if you have all the blood flowing to an alveoli that's not getting much air, you're not going to be very efficient at gas exchange. You want to shift most of that blood to an alveoli that's getting a lot of ventilation. Okay, or you kind of want to get them matched. So this is a local control. So changes in the partial pressure of carbon dioxide and oxygen in that area will cause local changes to both the bronchioles and the arterioles. So if you have an alveoli where carbon dioxide is high and oxygen is low, why would you have that situation? Well, that's poor ventilation. So what you will do to counteract that is you want to start matching the ventilation with the blood flow. So you could do that in two ways. You can dilate the bronchiole to increase ventilation and constrict the arterioles so that the perfusion matches, so that the amount of blood coming to that alveoli matches the amount of ventilation. Or you can have the opposite. If you have a really well-ventilated alveoli with poor blood flow, you'd have low carbon dioxide, high oxygen. So you can get them matched by constricting the bronchiole and dilating the arteriole. So that's why I remember way back when we looked at airway resistance, and one thing that said that will constrict bronchioles is carbon dioxide. So this is a little picture. Let's say here's my little alveolus. Okay, so this is a poorly ventilated alveoli, and this is a nice ventilated alveoli. So if I have a poorly vented alveoli that's getting a lot of blood flow, okay, I'm going to have an increase in carbon dioxide, decrease in oxygen, okay, and those local chemicals will cause the arteriole to constrict. Okay, so now I've matched my blood flow with the ventilation. This is just showing the changes to blood flow. Or if you have good ventilation, inadequate perfusion, you can dilate that blood vessel. And this is a nice little summary for you guys. It's showing you the bronchioles, pulmonary arteries. Okay, so if I have increased carbon dioxide and decreased oxygen, that's poor ventilation. Okay, so I'm going to dilate the bronchioles and constrict the arteries. It's the opposite. Good ventilation, poor perfusion, then I'd constrict the bronchioles, dilate the arteries. Now what's interesting is the pulmonary arteries act differently than your systemic arterioles, other places in your body. Because remember, you just learned in our last unit about local control of blood pressure. We talked about perfusion and the arteriole's response to stretch. And you learned that when the tissues are really metabolically active, you would have high carbon dioxide, low oxygen, and that would cause those arterioles to dilate. Whereas in the pulmonary circuit, it causes those same conditions cause the arterioles to constrict. It all has to do with the purpose. You know, here you're talking about airflow, here you're talking about metabolism. Okay, so it's kind of interesting to note the differences. One other thing I'll mention, we'll talk about this later, is when people enter into a hypoxic situation, let's say they're climbing high altitudes, they can sometimes suffer from what we call pulmonary edema. And the reason is when you're in a hypoxic situation, obviously oxygen levels decrease. And no matter how much you dilate the bronchioles, if you're in a low oxygen situation, it's not going to help. And those blood vessels will constrict. And what that does is it increases blood pressure in the pulmonary circuit, and fluid starts to shift out of the blood and into the tissues, and it causes pulmonary edema, which can be very dangerous when people are doing those high altitude hikes. Another thing that affects external respiration is structural characteristics of the membrane. Obviously, to have good diffusion of gases across that membrane, you need good conditions. And for diffusion, you want to minimize the distance and you want to increase the surface area, right? So the membrane is designed to be very thin. It's just those two simple squamous cells thick. So it's really thin, and that's efficient for gas exchange. And also your alveoli, it has a large surface area. All those little air sacs increases the surface area for gas exchange. So like for example, in males, if you actually laid out all the alveoli flat, you'd have about 60 meters squared of surface area. That's about 40 times that of your skin's surface area. Okay, or they say it's like the size of a tennis court, I believe. That would be the surface area you have for gas exchange. So things that will decrease external respiration is anything that hinders diffusion. So if I increase the distance that gases have to diffuse, that's going to affect my gas exchange. So any thickening of that membrane. So things that can cause thickening is inflammation, fibrosis, which you have scar tissue building up, mucus, or edema, because now you have more fluid on that membrane or between the membranes for gases to have to move. The other thing is if you decrease the surface area, that's going to minimize the area I have for diffusion. And this happens in emphysema. Okay, and I have a picture here. What happens is in a normal lung, you have the walls of the alveoli, and that increases the surface area. In emphysema, one of the problems is those alveoli walls start to break down, and so you lose surface area. You kind of end up with one big air sac instead of a lot of little air sacs. That's a generalization, but that's basically what's happening. So you've reduced the surface area for gas exchange. So emphysema has all sorts of problems. They not only can not get air out because it's a COPD, but then they also have reduced surface area for gas exchange. Or we talk about fibrosis, so if there's scarring of this tissue, it's harder for gases to diffuse across. And then this is showing you pulmonary edema. There's two places you could have fluid building up. You could have fluid building up in the alveoli here. So you can have mucus that builds up in there, or if you have inflammation, bronchitis, you have fluid building up there. So that increases the distance for gas exchange. The other place you can have fluid building up is between the alveolar wall and the blood, so actually in the cavity. And then obviously asthma, if you decrease ventilation, that's going to obviously then... So we just talked about all the things that affect external respiration. So we talked about partial pressure gradients, gas solubility, matching your ventilation to perfusion, and then structural changes that can happen in the membrane that will affect diffusion of gases. Okay, so those are 4 things that will affect gas exchange across that membrane, also known as external respiration. Now we're going to talk about how gases are actually transported in the blood. So let's first talk about oxygen. Oxygen, most of it is transported on hemoglobin, because remember the heme molecules will bind oxygen. Each hemoglobin molecule can carry 4 oxygen molecules. And when oxygen is bound to hemoglobin, we call it oxyhemoglobin, or you'll see it abbreviated HbO2, like you see here on this picture. Now I did say that a small amount, it's actually about 1.5, or here we're rounding up to 2%, will be dissolved in the plasma. So we say that red blood cells are loading oxygen in the lungs, and then when it will be transported to cells, the oxygen will dissociate from the hemoglobin and move into the cells. So why does it move into the cells? Well, partial pressure of oxygen is going to be higher in the blood, the arterial blood, than it is in the tissues, because the tissues are using the oxygen. So as they're using it, partial pressure is lower in the tissues than it is in the arterial blood, and that will move oxygen down its partial pressure into the tissues. So there's this graph called the oxygen saturation, or you can call it the opposite, dissociation curve. I think most people call it hemoglobin dissociation curve. How easily is oxygen coming off of the hemoglobin? Or you can look at how much oxygen is on the hemoglobin. Either way. Okay, so that's what we call it, saturation dissociation curve. So this chart is showing you the percent of oxygen on the hemoglobin. And you can see it depends on the partial pressure. So at the alveoli, the partial pressure of oxygen is 100, right? And at that partial pressure, about 98% oxygen is being carried on hemoglobin. So hemoglobin is about 98% saturated at the alveoli. Now as the blood moves towards the tissues, when you get to the tissues, the partial pressure of oxygen is 40. So what that will cause is oxygen to move from the blood into the tissues to its lower partial pressure. So at the tissues, a certain amount of oxygen dissociates from the hemoglobin and moves to the tissues. And at the tissues, what you'll see is that now there's about 75% oxygen saturation on your hemoglobin. So that means a little less than 25% of the oxygen that hemoglobin carries goes to the tissue. Now that should kind of shock you. So the hemoglobin, or the blood leaving the tissues, they're just resting cells, are not highly metabolically active, you still have about 75% saturation. That's pretty good. So remember back, I think I told you, what's triggering you to breathe is not that you don't have enough oxygen, because you still have about 75% saturation, okay, in the blood. It's that carbon dioxide is building up and causing your pH to drop. So that's really what's stimulating you to breathe. So like when you hold your breath, you take a breath and you feel that urge to breathe, you probably still have enough oxygen circulating. It's actually that the carbon dioxide is building up and you need to get rid of it that triggers you to take your breath. Okay. Yes, eventually you'd run out of oxygen, but it's usually that the carbon dioxide builds up faster than you're actually losing oxygen. Now, what you can see is if a cell is really metabolically active, like an exercising muscle, its PO2 may be about 20, okay, a lot lower than a resting cell, because it's using the oxygen faster. So then what would be the percent hemoglobin saturation? Well, you can figure that out. If you go to partial pressure 20, really metabolically active cell, then the hemoglobin saturation will be about 30%. So that makes sense, right? Obviously, if a tissue is more metabolically active, the hemoglobin is going to drop off more oxygen. It's going to dissociate more oxygen and be less saturated when it leaves that tissue. So some things that will affect how saturated the hemoglobin is. It's basically how active the tissue is, or what its partial pressure of oxygen is. So factors that will decrease hemoglobin's affinity for oxygen. If you're decreasing hemoglobin's affinity for oxygen, it means it's more likely to let the oxygen go, okay, and stop holding on to it. So it's basically anything that happens in a metabolically active tissue. Okay? If a tissue is really metabolically active, it's going to need more oxygen, and it's going to have a higher temperature because it's carrying out chemical reactions faster. Acidity will increase in that area because hydrogen ions are a byproduct of metabolism. Obviously, you'll have a higher PCO2 because if the tissue is more metabolically active. And then there's this thing called diphosphoglycerate, or it's also called BPG. You might see it as BPG, which stands for biphosphoglycerate instead of di. Both means two. But this is a chemical that's actually a byproduct of glycolysis, so that increases in metabolically active tissues. So all these things would increase hemoglobin's chances of releasing oxygen because it decreases its affinity to hold on to it. And the way that they do it is they actually modify the structure of hemoglobin, and as the protein changes shape, it drops the oxygen off, and it will unload from the hemoglobin. Okay, so like I said, all these parameters will be higher in the tissues, and that's where you actually want to unload the oxygen. So here's some graphs that show how these conditions will shift the hemoglobin saturation curve. So as temperatures increase, you can see if we still look at the partial pressure of 40, where the tissues are, okay, I told you usually at normal body temperature you'd be at about 75% saturation. But if you increase the temperature, hemoglobin is going to release more and only be at about 55% saturation when it leaves. Okay, so it's dissociating more oxygen. Or you can look at carbon dioxide. As partial pressure carbon dioxide increases, you release more oxygen. Or if as acidity increases. This shift caused by acidity is called the Bohr shift. And then you can also see the same with DPG. So let's summarize the different factors that play a role in oxygen concentration of your arterial blood. So total O2 content that will affect it. Obviously, your oxygen saturation of your blood depends on your hematocrit and the amount of hemoglobin you have. So your hemoglobin per red blood cell, or the number of red blood cells you have, will determine how well you can carry oxygen. Also, how well saturated your hemoglobin can be. And things that will affect the saturation of hemoglobin that we just talked about is your partial pressure of carbon dioxide, pH, temperature, and diphosphoglycerate. Now, the amount of oxygen that gets dissolved into the plasma, this has to do with external respiration, which we talked about. We talked about just the composition of air. The only time that this is really going to play a role is As you increase in elevation, the partial pressure of oxygen can change. Ventilation, okay, how well you're ventilating the lungs, and we talked about things that affect ventilation, rate and depth of breathing, lung compliance, airway resistance will determine how well you can get the air in and out. The diffusion between the alveoli and the blood, we talked about that surface area plays a role, and diffusion distance, things that can affect diffusion distance, structural changes, membrane thickness or fibrosis, or amount of interstitial fluid like edema or mucus can affect that. And then remember we talked about matching perfusion with ventilation. Okay, so it's kind of a little concept map summarizing those things that affect arterial oxygen concentration. Now you've gotten the oxygen to the tissues. Now you have to have what we call internal respiration, which is the gas exchange between the blood to the tissues. So oxygen is going to diffuse into the tissues to be used for cell respiration, and carbon dioxide is being made by the tissues from cell respiration, and it needs to get into the blood so it can be carried to the lungs so you can exhale it because it's a waste product. So how do we transport that carbon dioxide that's now moving into the blood from the tissues? Well, there's 3 ways carbon dioxide can be transported. Some of it just gets dissolved in the plasma as carbon dioxide. That's about 7%. Some is also carried on hemoglobin. So all of us are very familiar with that hemoglobin carries oxygen. Okay, and that's the main way we can carry oxygen in the blood. But hemoglobin can also bind carbon dioxide. So about 23% of your carbon dioxide is carried on the red blood cell. When hemoglobin is mostly carrying carbon dioxide, less oxygen, we call it carbaminohemoglobin instead of oxyhemoglobin. Now carbon dioxide binds to a different site than oxygen. Okay, so it doesn't compete with oxygen. And when the carbon dioxide loads on to the hemoglobin at the tissues, it kind of changes the shape when it binds to the protein, and that increases the dissociation of oxygen. Okay, so it works together. So that's why increased carbon dioxide will decrease hemoglobin's affinity for oxygen, make it likely that it lets go of the oxygen. Now, carbon monoxide actually binds to the same site on hemoglobin as oxygen. So that's why carbon monoxide can kill you, and it's a poison because it outcompetes. It has a stronger affinity for hemoglobin than oxygen does. And so if carbon monoxide is present, it will bind to where the oxygen is supposed to bind. So now your hemoglobin can't bind the oxygen. So that's how it can kill you. If you catch it fast enough and you get to a hospital, they can try to outcompete the carbon monoxide by obviously removing you from the environment where the carbon monoxide is and then treating you with 100% oxygen. So you're just trying to outcompete the carbon monoxide. So if you catch it early enough, you can kind of give yourself oxygen and outcompete it. But most of your carbon dioxide is transported as bicarbonate in the plasma. So it dissolves and it gets changed into bicarbonate and it's carried that way. You're mostly loading carbon dioxide into the blood at your internal respiration. So from the tissues, carbon dioxide is being created by the tissues, and it's going to diffuse from the tissues into the blood, because in your arterial blood, there's less carbon dioxide. Some of it's just going to dissolve as carbon dioxide, about 7%. About 23% of it will bind to hemoglobin. But the other 70%, what will happen is it will diffuse into the blood, and you have the enzyme carbonic anhydrase. And what it does is it will combine with water to form carbonic acid, which quickly dissociates into bicarbonate and hydrogen ions. You've already learned this equation when we talked about buffering. It's going to be transported as bicarbonate. Now what's interesting is this hydrogen ion actually binds to hemoglobin. So hemoglobin acts as a buffer. So it keeps these free hydrogen ions that are being created from changing your pH. And that is why increased pH will increase the dissociation of oxygen. Because when hydrogen binds to the hemoglobin, it also causes the hemoglobin to release the oxygen. So you kind of see what's happening here. Hemoglobin's carrying the oxygen to the tissues. And when anything else binds to a protein, it causes it to change shape. So when that carbon dioxide and that hydrogen ion bind to the hemoglobin in the tissues, it causes the hemoglobin to change shape and release the oxygen. So it works out perfectly. Then what happens is the bicarbonate will diffuse from the red blood cell into the plasma. And this is what we call the chloride shift. Because what happens is you have a transporter in the membrane of your red blood cell. It's an antiport. It transports bicarbonate to the plasma. But if you're shifting a negative ion into the plasma, to stay electrically neutral, you got to shift another negative ion into the cell. And so you shift chloride. So it's called the chloride shift. To counterbalance the outrush of negative bicarbonate, the chloride ions move into the plasma, or from the plasma into the erythrocyte. So that's at the tissues. Then the red blood cell gets transported to the lungs. And now you need to unload the carbon dioxide so the carbon dioxide can diffuse into the alveoli so you can get rid of it. So now you have the reverse chloride shift, where now the bicarbonate moves back into the red blood cell and the chloride shifts out. And what will happen is, so now oxygen at the lungs is loading onto the red blood cell because it has a higher partial pressure there than it did in the tissues. So now when oxygen binds, it causes the hemoglobin to release the hydrogen ion, and the hydrogen ion will combine with the bicarbonate that's coming in to produce carbonic acid, which will then be turned into water and carbon dioxide. So it's just the reverse reaction that happens at the lungs. And now the carbon dioxide will diffuse into the alveoli because it has a higher partial pressure in the plasma than it does in the alveoli, and you'll exhale it. So the carbon dioxide dissociates from the hemoglobin if it was bound to the hemoglobin. If it was just dissolved in the blood, it just diffuses out. And if it was being carried as bicarbonate, the reverse reaction will turn it into carbon dioxide and it will be exhaled. This picture, I like this picture because it's showing both what's happening with oxygen and what's happening with carbon dioxide at the lungs. So it's the conditions that trigger the loading and unloading of these gases. So you know that at the lungs you have a higher partial pressure of oxygen than you do in the blood. So the majority of the oxygen will move in, it will bind to hemoglobin, and when it binds to hemoglobin it displaces the hydrogen ion that hemoglobin was carrying from the tissues. So now I have more oxyhemoglobin, and this hydrogen ion that got displaced can bind to the bicarbonate that's coming back in from the reverse chloride shift. And when they bind, it produces carbonic acid, and the enzyme will turn it into water and carbon dioxide, and the carbon dioxide will diffuse out. And then you also had some carbonic anhydrase, the enzyme that converts bicarbonate in the plasma. So it can happen in the plasma, but the enzyme works a lot slower than it does in the red blood cell. So that's why the bicarbonate comes back into the red blood cell to get changed over. And then of course you have some carbon dioxide that's just dissolved as carbon dioxide that will diffuse out, and you had some carbon dioxide that was bound to the hemoglobin that will unload when the oxygen loads, and it will shift out. So basically you need to remember that oxygen is mostly carried on hemoglobin, it's loaded at the lungs, it dissociates at the tissues, and carbon dioxide is going to load onto hemoglobin at the tissues and dissociate at the lungs to get rid of it. And carbon dioxide can be carried in three ways. Just dissolved as carbon dioxide, it can be carried on the hemoglobin, but the majority of it is transported in the blood as bicarbonate. Now let's talk about the control of respiration. The control system for respiration is in the medulla, and also the pons plays a role, which we'll talk about. But there's two groups in your medulla. There's the dorsal respiratory group and the ventral respiratory group. The dorsal group, which you see here, is the pace setter for the respiration. Okay, it sets your normal respiratory rate, and that's called eupnea. That's your normal breathing rate, and that's about 12 to 15 breaths per minute. So this dorsal group will initiate action potentials that will lead to your internal intercostals and the diaphragm, and it will trigger them to contract and trigger inspiration. and then those neurons become dormant during expiration. So they basically stop firing action potentials, and that will cause those muscles to relax, and it's passive exhalation. Now the ventral group is only involved in forced expiration. So it will initiate an action potential to your muscles and cause you to forcefully exhale. So what that means is when you're passively breathing, doing your tidal volume, your dorsal respiratory group will stimulate the muscles to cause inspiration, and then they just stop stimulating the muscles and the muscles will relax to cause passive expiration. But if you want to forcefully exhale, then you're going to have action potentials sent from the ventral respiratory group to stimulate those muscles to forcefully exhale. In addition to the medulla, the pons also plays a role in controlling respiration. The pons and the medulla work together. Basically, the pons helps smooth out inspiration-expiration transitions. So it works as a negative or an inhibitory neurons that travel to the dorsal respiratory group in the medulla to inhibit the inspiration, and then that will cause the neurons to stop firing from the dorsal respiratory group, and it will initiate expiration. Now beyond the medulla and the pons, there's some other areas of the brain that can influence the output from the medulla. One is your cortex. So remember, the cortex of your brain is all your conscious motor control. So you know consciously you can choose to take in a deep breath or hold your breath voluntarily. So in that case, you're deciding to do that on your own, and the impulses will be sent from the cerebral motor cortex and will bypass medullary controls. So usually the medulla and the pons are doing the reflex where you just quiet breathing, you don't even have to think about it. But then if you do think about your breathing and you want to change the rate voluntarily or take a breath or hold it, then your cortex will be controlling that. There's also some respiratory responses to emotions. And you know, like with your fight or flight, you start increasing your respiratory rate or if you're scared. So that's controlled through the hypothalamus, because remember, your hypothalamus is part of your limbic system, and so it can modify rate and depth of respiration. For example, some people have really weird respiratory responses to different emotions, and some people can be very different. For example, some people, when they get angry, they might get so angry they hold their breath. Other people, when they have anxiety, they might hyperventilate. So those are emotional responses that affect rate and depth of respiration. There's 3 chemical factors that affect the rate and depth of breathing through the medulla. The 3 chemical factors that can affect ventilation is carbon dioxide levels of the blood, oxygen levels of the blood, and arterial pH. Okay, so we're going to talk about these 3. I've mentioned before that it's actually the carbon dioxide levels that are building in your blood that are the main regulatory chemical for respiration. Remember I said, like when I was a kid and you hold your breath, I thought that the reason that urge to breathe was because I needed oxygen. Well, technically, remember, it's that you actually have to get rid of that carbon dioxide, because remember, carbon dioxide, if it increases in the blood, it will drop your blood pH, make it more acidic. And we've learned that that's very dangerous if your pH becomes acidic. If you have increasing carbon dioxide levels, that will increase your respiratory rate, because through respiration, that's one way you can flush that carbon dioxide out of your system. Now, the changes in carbon dioxide are detected on what we call central chemoreceptors. If it's a central chemoreceptor, that means it's in the central nervous system. If it's a peripheral chemoreceptor, it means it's a chemoreceptor outside of the central nervous system. So the carbon dioxide is detected on a central chemoreceptor because the receptor for it is in the medulla oblongata. And we'll talk a little bit more about this. Now, oxygen levels, they're detected in peripheral chemoreceptors that are found in the aorta and carotid artery. And then that information will get sent to the medulla from the chemoreceptors through the vagus nerve. And then we'll also talk about arterial pH, where that's detected. Arterial pH is also detected in the arteries, the carotid artery. So let's look a little more at carbon dioxide levels and how they increase ventilation. So as pCO2 in the blood rises, that's called hypercapnia. When you have increased carbon dioxide levels, it will increase ventilation. How it does that is the carbon dioxide in the blood will diffuse into the cerebral spinal fluid, and then it will get what we call hydrated, the chemical reaction where it turns to carbonic acid and then dissociates into bicarbonate and hydrogen ions, and then those hydrogen ions will be detected by a chemoreceptor in the medulla. He's the control center. He decides to increase ventilation. That will be your response, but he'll send that information out motor neurons to your effectors, which will technically be your respiratory muscles. Now, when pCO2 levels get too high, one compensatory response your body has is to trigger hyperventilation. And hyperventilation is when you increase the depth and rate of breathing. And the purpose of that is it will quickly flush out carbon dioxide from the blood. Some people hyperventilate because of anxiety, but other people might hyperventilate because of acidosis. If their carbon dioxide levels are getting too high, that's one response. Some people will start hyperventilating because of ketosis. Remember we talked about ketoacidosis? It can happen in diabetics where they are using fatty acids for metabolism, and that causes the production of ketones, which can drop the pH. So they may be triggered to hyperventilate. So if someone's hyperventilating, we used to always say, okay, give them a bag to breathe into, but that's actually a problem if the person is hyperventilating to get rid of their carbon dioxide, if it's the body's compensatory response. Because if you give them a bag, now they're just re-inhaling the carbon dioxide. So it is kind of important to think about that, why someone's hyperventilating. If it's because of just anxiety, then yeah, they can breathe into a paper bag because that causes them to slow down their breathing and get back to normal. If it's because it's a body's natural compensatory response, that's not such a good idea. Alright, hypoventilation is slow and shallow breathing. So your body can naturally put you into hypoventilation if you have abnormally low carbon dioxide levels for some reason. Apnea, you probably have heard of sleep apnea. It means that you stop breathing in your sleep. Apnea refers to that you stop breathing. So some people it might trigger apnea where they kind of hold their breath for a second. They might not even realize that they're doing it, and that's to let their carbon dioxide levels rise a bit. Alright, if we look at PO2 levels, I think this is interesting because it's the carbon dioxide levels that really trigger your medulla to set the rate and depth of breathing. Now, oxygen levels are being monitored, though, by the aorta and the carotid bodies. But oxygen won't be your trigger to increase ventilation or decrease ventilation until there's a substantial drop in the arterial PO2. So, if your O2 drops significantly, then it will become a stimulus to increase ventilation. Now, a drop in oxygen is called hypoxia. So for some reason, you're in a hypoxic situation, despite your carbon dioxide levels building, then oxygen will become a trigger. So why would you be in a hypoxic situation? You could have normal carbon dioxide levels, but be in a hypoxic situation. For example, when you go up to higher altitudes, you could be producing normal amounts of carbon dioxide. Your carbon dioxide isn't building, but your oxygen levels could drop significantly, and that will trigger you to then increase your respiratory rate. Now, what happens in people with emphysema or some other of your COPDs it can happen in, remember we talked about how they have trouble getting air out. And so what happens is they retain carbon dioxide and their pCO2 levels are elevated. They get used to those high elevated carbon dioxide levels. They've actually seen that high carbon dioxide levels can actually damage the receptors in the medulla, they become less sensitive to the carbon dioxide levels if they stay high for a long time. Now, the carbon dioxide isn't their trigger to breathe. And so they have what is called the hypoxic drive. Because now the only thing that's going to stimulate them to breathe is when their PO2 levels drop significantly. Their urge to breathe is caused by their PO2 levels dropping. Now, this comes into play when you treat someone with emphysema, because if you give someone with emphysema 100% oxygen, what you're doing is you're removing their urge to breathe. They'll go into apnea, where they'll stop breathing, because they actually have to wait for their oxygen levels to drop to breathe. They'll give them oxygen, don't get me wrong. You'll give someone with emphysema oxygen, but they usually don't want you to give them a high saturation of oxygen. So CO2 levels building is your first thing that will increase ventilation. If your O2 levels drop significantly, then that will become a stimulus for increased ventilation. And the other thing is just arterial pH, besides carbon dioxide influencing the pH. You have hydrogen ion receptors in the carotid bodies and the aorta, and they're going to detect blood pH. Even if your carbon dioxide and oxygen levels are normal, if your pH is becoming acidic, it will increase ventilation. In what situations would your carbon dioxide levels and your oxygen levels be normal, but your pH is dropping? Beyond carbon dioxide retention, there's some metabolic reactions that can cause your pH to drop, such as when you're exercising, or if you accumulate lactic acid in the blood, that can cause your pH to drop. Or like we talked about, using fatty acids for metabolism, which happens in people with diabetes, and they enter into ketoacidosis. Alright, so here's just a little summary. The stimuluses that can cause you to change your respiratory rate and depth. We talked about that could be emotions or voluntary control. So through your limbic system or the cortex, it will trigger the pons and the medulla to stimulate the motor neurons that go to your respiratory muscles and either increase your rate or decrease your rate of breathing. Or your carbon dioxide levels get detected in the medulla, and that will stimulate your respiratory muscles. And then we talked about oxygen levels and pH, which get detected in the carotid and aortic chemoreceptors. That information gets sent to the medulla through your sensory neurons, specifically the vagus nerve. Okay. And then here you can kind of see your dorsal respiratory group. It controls the somatic neurons that control inspiration, and then they just get inhibited, and those muscles will relax. If you want to voluntarily exhale extra beyond your tidal volume, then you'd use your ventral respiratory group would trigger that. Alright, a few other little things I want to talk about with the respiratory system is some other respiratory reflexes you have. There is what is called the irritant reflex, and you probably are all familiar with this. It's if any allergens or irritants enter into the air passageways, you'll have constriction of the bronchioles. And that's a protective mechanism, so hoping that that irritant doesn't get down into the alveoli. Then there's also called the inflation reflex, or the Herring-Brewer reflex. And this is a stretch reflex. And when you inhale, stretch receptors in the lungs are stimulated, and it triggers you to stop taking air in, and it initiates exhalation, okay, or expiration. It's designed so that you don't overinflate your lungs. In adults, they've seen that it doesn't really play a role, but they have seen it in infants when they take in a breath, that this reflex kicks in so that they exhale. And then some other things about high altitude and how that affects your respiratory system. When you move to a higher altitude, the PO2 drops, and so the PO2 in your blood will drop, and some people can become hypoxic. So movement to high altitude can often cause some symptoms or some problems called acute mountain sickness. And the symptoms of acute mountain sickness are a headache, shortness of breath because of the low PO2, nausea, and dizziness. And what's happening here, it can be life-threatening. There's some people, if they don't detect the signs of acute mountain sickness and do something about it, such as descend from the elevation that they're at, they can get some more severe illnesses like high altitude pulmonary edema and high altitude cerebral edema. The pulmonary edema is when fluid shifts from the blood into the pleural cavity. And this is caused by those local controls. Remember we talked about the perfusion to the alveolus, and if there's low PO2 in that area, we talked about that the blood vessels in the pulmonary system would constrict, okay, because they're trying to match ventilation with blood flow. And if they detect a low PO2, they think that it's poor ventilation and the blood vessels constrict. However, it's just that you're at a high level and the PO2 is lower. And so that creates a higher pressure in the system, and that will cause fluid to move from the blood into the tissues. And it's dangerous. These people will start coughing up like a foamy, pink, bloody sputum, and it can be life-threatening. And then some people also have high altitude cerebral edema, and this has to do with how the blood vessels in the brain react to a hypoxic situation. Because of the low PO2, the blood vessels in the brain, when it's hypoxic, they actually dilate and they become really permeable. And the reason they're doing that is because the brain wants all the oxygen it can get. So it's trying to get more blood flow and it's trying to become more permeable. Well, the problem with that is you can also have fluid shift from the blood into the cranium. Now this is super dangerous because if you have edema in your cerebrum, because of the skull, there's nowhere for that pressure to go except back onto the brain, and it can cause brain damage and death. If you have acute mountain sickness, kind of the way to treat it is to first descend, come to a lower elevation. You can also take in oxygen with a tank of oxygen, or they can use hyperbarometric chambers, which actually increases the pressure of the air so that more oxygen will get into your blood. Now, if you are in hypoxia, because, for example, you live at a higher altitude, you can acclimate to it, as long as you do it slowly. So there's different ways. You can either have your respiratory compensatory response, and then there's also a hematopoietic response. So the first thing that will happen is you'll increase your ventilation. So you can increase your ventilation to be about 2 to 3 liters per minute higher than what you would be doing if you lived at normal sea level. And the way that this is triggered is they've actually seen in hypoxic situations or at higher elevation, the chemoreceptors become more sensitive to the carbon dioxide. And then if there's obviously a decline in PO2, that will trigger the increased ventilation. The hematopoietic adjustment is that we learned in our blood chapter that the kidneys will produce the hormone erythropoietin when oxygen levels of the blood drop, and erythropoietin triggers the production of red blood cells. So you'll increase your hematocrit, and if you have a higher hematocrit, you're hoping that you have more red blood cells to carry more oxygen. Now this is a slower response and takes longer to acclimate. That is it for respiratory system, and next we'll be talking about your digestive system.